Well, hello. This is Paul Feuerstein, the editor-in-chief of Dentistry Today, and we are going to talk about some really interesting stuff right now. We've been talking a lot about artificial intelligence, and we've been talking about dental practice, but I don't think I've ever really spoken to someone who's using it and using it in a very, very great manner. So this is Michael Scialabba, who is the Chief Clinical Officer at 42 North Dental in Boston, out of Boston. And Michael, how are you today?
How you doing, Paul? I'm doing well.
So tell me a little bit about you and what is 42 North? We got about an hour.
Great. So 42 North is a DSO. It's a regional DSO in the Northeast, and I would call it the upper eastern part of the Midwest. We go from Maine to Michigan, and we're a multi-specialty group practice. We try to mimic group practice, private practice as much as possible. And when I say multi-specialty, we layer in specialty into our practices. And our practices tend to be on the larger sides. When it comes to accommodating our patients, we tend to have offices that are about 9 to 10 chairs or more. We have 3 offices that have 18 chairs. So we're really looking to provide the services to our patients to get the best clinical quality and outcomes they possibly can achieve.
The beauty, I mean, I've been to some of the offices. The beauty is it's one-stop shopping for the patient. They're not bouncing around from specialist to specialist.
Convenience of care is one of our pillars that makes our company. We believe in access to care. We believe in convenience for our patients to receive early morning appointments, evening appointments, weekend appointments. We have some offices open on Sundays, and especially in the urban areas, and they've done extremely well. So breaking down those barriers to care is really important.
The things I've seen over the years with 42 North and its subsidiaries is that there's legitimate peer review internally, and it's not just everything is monitored. It's not just some dentist popping in there to work for a few days and disappear on you. It's well managed, and I'll use that word peer review. There's probably a better word than that.
That's a great segue into what makes, I think, us special is that when you have more than one doctor in a practice, there's oversight. When you add 4, 5, 6 doctors in a practice and have to coordinate care with specialists, that's more than oversight. That's coordination of care. And I think the segue I was mentioning earlier into AI allows us to calibrate care. So we can go into that in a few minutes here, but I think calibration of care is something we always try to achieve. When you're in a group practice setting, in the old days, when I was practicing full time, you would have a senior doc and a junior doc, and you'd work together, and you would always want the junior doc to treatment plan similarly to the senior doc so that the patient had the same experience. But it took time for that junior doc to treatment plan similarly. They may have went to a different school, residency program, saw things differently, may have been up to date with different technology and different treatment opportunities. But now with AI, and we'll go into it, it allows the treatment planning segment of the patient care to be very transparent and to be very uniform.
That's the big word. Uniform, I think, is the word. Not standardized, but uniform. That's a big difference too.
Yeah.
So let's go ahead.
No. So I think that's what one of the things that we try to achieve is at 42 North, not only do you have your colleagues that are in the single practice that have that the collaboration, that oversight, we also have what's called a clinical management team, which are doctors from all over, and all the specialties are represented, all the geographies are represented, where they volunteer their time, come together to help set the clinical standards that we want to achieve for our patients. They measure clinical outcomes. We have clinical metrics that we review. Being on one practice management software across our entire platform allows you to achieve that. They look at different technologies that we want to implement. They look at our formularies for preferred vendors and labs and really help pick out the best quality items so that our doctors can get the best pricing and tools to provide the care that they want to deliver in their practice.
That's great, and that's, I mean, that's just the beauty of a larger situation, because you have a lot more control over things, but you also have access to certain things. But more importantly, what I've seen, and I'm just being a little bit of a homer here because I know this 42 North pretty well. the patient care is terrific, and the patients aren't walking out thinking that they're just like number 33 coming out of out the door. And I think there's still, even though it's a large corporation type of a situation, it still feels, each practice seems to feel like its own practice. That's the way I see this, like
Yeah,
a private practice was.
absolutely. You always hear the saying, politics is local, dentistry is local. Dentistry is about the relationships that individual doctor builds with their patient. If you don't build that relationship, don't build up that trust, the fun things we do in dentistry never get accomplished. The patient who's in immediate pain, the patient who has an infection, those patients are going to come in and get treatment no matter what the situation is. But it's the combination, prosthetic and orthodontic cases. It's the fun things that we like doing, that we get trained to do, that you never get to achieve if you don't build that trust.
Perfect. Perfect. So now we have this little specter all over us. Everybody's talking about artificial intelligence. So just as a segue, several years ago, I was involved in helping the computers learn how to read X-rays. I personally read in a project something like 6,000 X-rays, 6,000 bite and a few friends of mine did. I think we did about 30,000 X-rays and fed it to a computer, and the computer was strictly learning how to read caries, which is interesting. And one of the things that we found was that in every practice, every GP works the same way. You're working on a patient, and then the hygienist says it's time for a complete check, and you're right in the middle of taking whatever you're doing. So you run into the room, you look at the screen, and you go, yeah, I think I see something over there, and whatever. And with AI, as we'll talk about, the computer is actually reading that before you got into the room. And not only is it reading it, but it's not reading your monitor. It's reading the file. So you could have a monitor you bought in Walmart or a monitor you bought, for $10,000. It'll be a difference of what you're seeing, but the computer's looking at the raw images. And before just to preface this, since I've been working with them so carefully, I'm working with a number of companies, including Videa, with Florian Hillen and some other companies. The computer's not saying, this is what you must do, doc. All it's doing, I call it Jiminy Cricket, for those of us old enough to remember who Jiminy Cricket was. It's on your shoulder, and you're walking into the room, and you're rushing in the room, and there's little highlights. It says, check this, check this, check this. It's not saying do this, it's saying check this. It's giving you a little bit of a background. So leading into that, you've embraced this. And so talk about how this whole thing just operates within a dental practice, never mind a large practice, small practice, any dental practice, really.
Yeah, you laid it out nicely. You're exactly right. Most X-rays are taken in the hygiene chair, and doctors are tapped on the shoulder. I need an exam, and the doctor goes in, and they're preoccupied worrying about the patient that they're currently treating. So we don't want to make mistakes and don't want to miss something, but it happened to me, and I've been practicing for 20 years, and I'm the chair of the dental board in Massachusetts. And I realized that I missed something one time. It makes you feel really bad. It makes you feel guilty. I missed a K underneath a crown. And it was one of those things where the patient came back 6 months later, and the hygienist goes, I think you need to look underneath tooth number 18. I go, why? She's like, my Explorer disappears. So I go in, I'm like, how did we miss this? So I pull up the old X-rays, and I go like this. I said, holy cow, how do we miss it? So guess what? We missed it. We were human. I can't remember what happened that day when that patient was in, but when you as a practitioner realize that we're human, we make mistakes, and this is a software that's going to help you avoid making those mistakes, how do you not embrace it? So the way we implement it is the hygienist takes the X-rays, the findings pop up on the screen, the patient is now inquisitive, saying, what are those boxes? What do those lines mean? Because the AI finds opportunities for decay or opportunities for you to evaluate decay.
Yeah.
It measures bone loss, and it also finds periapical lucencies or periapical pathology. That's on a radiograph. So with that, it starts to be a transparent discussion with the patient before the doctor even gets to the room. Doctor will come in, and they'll go through all the findings. And then they'll also look at the radiographs as a whole, do the exam. And they'll determine what the recommendations may be. What I can tell you is that we have also done a pilot with a particular third-party payer on preventative dentistry, meaning adult fluoride, silver diamide fluoride, curodont for adults, things that historically have not been covered. Our doctors in the offices that have Videa are diagnosing early stage decay at 2 times the rate of a practice without the technology. So what ultimately will this do? This is going to allow us to treat patients earlier in the disease state, prevent that decay from progressing, potentially using chemotherapeutics that we've been hearing for years that are going to prevent decay from progressing. Well, if you can't diagnose it early and you wait until you have to treat it with a burr, you're never going to get to that point in treating and preventing decay from progressing, and we're not going to do anything to improve outcomes.
And it's hard for me in my heart to see some fairly incipient thing on the film and then say, I'm going to make a hole 55,000 times the size of this
Exactly.
tooth. But we have this stuff called SDF or whatever, and we can use this and use it carefully, by the way, because it makes a mess sometimes.
Well, yeah, but so Curodont is a great example that doesn't make a mess. So Curodont's a product it's clear, it doesn't change the tooth color, and you can use it into proximal, facial, in early lesions. And what we're finding is when patients are given that option, the acceptance rate is in the 90s.
Of course.
Okay, 90% acceptance rate for things that if you were to, in the past, if you didn't have this technology alongside the doctor when they tell an adult patient you need to have fluoride, the acceptance rate's in the 30s that we found.
Well, the big problem is, and I was trained a zillion years ago with amalgam, and we had this thing called a watch, and what it meant was wait until it gets big enough to fill with amalgam.
Right.
And that's why that's actually helping my practice now. I have all these gigantic amalgams that are failing doing crowns. But I was, so there's a new watch out here. The new watch is the computer is saying, really watch this, really now, watch it now before anything does happen. You can remineralize these things, and that's a big deal. And I think that's really great. So how does it actually? So what's the actual process is that essentially let's say it's an FMX. So you're looking at 18 X-rays, and then again, I'm coming into that room and I look at, oh my gosh, I got to look at 18 X-rays now. The patient's, hanging. There's some saliva eject hanging on my patient's mouth, and this is doing it for me basically. But it's not.
This is identifying the areas you need to look at. Yeah, exactly. Right. And what we found is before we implemented it, we know Videa did a study with the FDA in order to get approved, but we took the exact same test with our doctors, and it was really eye-opening. And I was one of the doctors that took the test. Our doctors tested better than the general doctor population that Videa chose to get the FDA approval. Videa chose, I think there were 31% additional lesions identified. We were about 21%. So using Videa, we found 21% additional areas of concern that we agreed with the software than we identified without it. So what they did was they gave you 100 X-rays without Videa, and you had to go ahead and pick what you saw as decay. Then they gave you the same X-rays in a different order, obviously, but red boxes, identifications. Then you had to agree or disagree if the red box identified decay. And the accuracy was tremendous. What blew me away was not the bone loss, because I think you see the bone loss, but believe it or not, there are practitioners that miss it. It's the periapical lucency that was really eye-opening. And this is something that is right now it's in beta testing, but the combination of the decay and the periapical lucency, there were areas that I basically going through did not see the gradient change of gray until it was highlighted for us. Because when you're talking about that bone, when you look at an X-ray, you see the bone, you see a lighter gray, darker gray, but then when they highlight it for you, it's so obvious. It's really amazing. That stuff should never be missed ever again.
I have an odd question, and I need an honest answer. is when you mentioned that the patient sees the boxes, they look at the x-rays.
Yeah.
Is it looked at by the patient as the doctor's here, but this is like a second opinion, or it's like the validation or the verification?
Yeah.
And does it
That's
help in explaining disease to the patients?
yeah, that's great. So we give our doctors the autonomy to use the software how they like it, as long as we want them to use it. So some look at the x-rays back in their office and then go into the patient's treatment room and discuss the findings. And then we'll show the patient what Videa shows. Others will have it up. What we found in both ways is that the patients look at it as a validation of the discussion of their findings. And you're exactly right. It's almost like a independent second opinion. And almost all of our doctors, almost all of our patients, when I say almost all,
yeah,
90% have said that they only want to go to a practice now that has this.
That's crazy.
You get that one person who's like, this is too much information for me, and I can't believe a computer is doing this, and it's like Big Brother 1984 Orwellian.
Yeah,
that sort of concept that you're going to get with doubters or people who don't want in certain things in their lives, which is fine. But the overwhelming majority were not only impressed, but they felt that we were being transparent and more trustworthy because
and more thorough.
Absolutely.
Yeah, because some of the naysayers I hear talking to me in my classes, they'll go, yeah, but aren't dentists going to use this as a selling tool and increasing their production? I said, well, not really. I mean, if that's your attitude in dentistry, then you're in the wrong place. I mean,
I think that's exactly right. Listen, if you do what's right for the patient, you're doing what's right for the practice, and you're doing what's right for yourself. So if you do what's right, you're going to have good outcomes. Good outcomes will result in proper remuneration.
Yeah.
Okay. This takes away the we've all gotten it. Somebody comes new to the practice, or
oh yeah,
I love the ones when I get a letter. You know, we've always seen it. I see it on the dental board too. Sometimes you get a letter, and my previous doctor told me I needed to have 20 fillings. I went to my childhood doctor who says I only needed 2.
Right.
Well,
right.
It's all dependent upon the level of diagnosis that they're looking at. And if you look at the x-rays, could they both be right? You know?
Well, you know that if there are 20 dentists looking at a situation, there's 25 different answers.
Absolutely. And what I think is, going back to what I said earlier, uniform. When you go to a group practice, you want to be able to go to every doctor in that practice and get a recommendation that's proper for you as an individual, because every treatment plan needs to be individualized. When we go ahead and give blanket treatment plans to everybody in the practice, that doesn't make any sense, nor does it's too prescriptive. So if you're giving individualized treatment plans, the key is to have a uniform approach to the diagnostic process.
And this is just one tool. I mean, we have a term that I use with a friend of mine. We said, don't check your brain at the door. And because I've been, we're using things like way back from Diagnodent and things like that, and transillumination. So you have to use all of your dental tools. So if you see something that's suspicious, you might want to say, well, I don't know. Let's transilluminate this too. Let's do something else. Let's let's light it up. Let's take an intraoral photo. Let's do something else to make it a little more interesting for me diagnostically. It's just one more tool in your toolkit.
Well, exactly. I think that all those things you mentioned, the Diagnodent, intraoral photographs, we're big believers, and we basically have every single one of our offices has an iTero scanner. We have 132 in our fleet. Basically, the interaction with the patient to make it more transparent and to have the patients participate in the co-diagnosis process is so important. And if this is another tool to make that happen.
This is aging me, but the founder of this whole process was named Dr. Robert Barkley. He was in the 70s, and these are the days we used an SLR camera to take photos of his patients. But he always believed in co-diagnosis, and to such an extent that he would do the whole treatment review, x-rays, photographs, and put it in the patient's hands and walk out of the room and say, what do you think you need? And it's just like, I mean, there's been so many situations where I'm using an intraoral camera and there's a obvious fracture. I'll take the image, I'll put it up on the screen, and I will leave the room, do my hygiene check, and come back and they go, what the hell is that crack over there? You know?
Yeah.
And so again, with the AI on the x-rays, the patient can look at that and say, does that mean something important? Can you explain that to me? What's going on here? And so I think the whole thing is, so well, I gotta, so where is this going? Where is this all going for us, AI?
A good question. I think we're in the early stages. I think we're only in the first or second inning. It's coming on fast. There's there's a lot of competition out there. There's more than one company that's doing it.
Oh, sure, yeah.
Yeah, I think that the key here is, what will AI allow the industry to do, and where will it go from there? And it's ultimately, it's how it's integrated. The diagnostic process is the easy part.
Right.
It's implementation of any technology is difficult. It's acceptance that the technology is not only a tool, but listen, medicine has accepted Watson, University of North Carolina, Columbia University, they're using Watson to diagnose cancers. And not even getting the doctor involved in the differential. It's like, let Watson determine what it is. Here's the sequence of observations and from the diagnostics, and Watson comes out and says this is what it is. So I think that once you get the acceptance by the doctors that this is not only a tool that will help you, but is more accurate than your own eyes, that acceptance will trigger a wave of bringing it into your practice. Once it's in your practice, it's how do you use it? And I think that is where we're scratching the surface. Ultimately, we have to find a way to work with the payers, because the payers are using this now as well.
Yeah.
So if we can bridge that gap, eliminate costs, make dentistry more affordable, more accessible to more people, adjudicate payments faster, because we're on the same platform, or we're both using AI, there is no reason to deny certain claims. There really isn't, because we're using a software that has basically certain criteria built into it that says this is what a crown should be based upon the standards that are set by, whether it be the third party or by the industry itself. And if the industry doesn't get involved, and I mean that the ADA and other thought leaders in dentistry don't get involved in the definition of the standard of care and what quality dentistry really is, then that's the problem. But I think ultimately this is where it's gonna go. It's gonna help the claims process faster.
Well, it quote levels that playing field too.
Levels the playing field. Integrating it into the practice management software, which Vidya has already done, being part of Henry Schein Dentrix Ascend, is a huge game changer. It's to me, it's a game changer, complete game changer. But ultimately, we all want to get, at the end of the day, you go into medicine, you go into dentistry to basically make other people's lives better. We've made a sacrifice to do that. And if the goal is to make people's lives better, healthier, this is a tool that helps identify problems at an early stage. And the earlier you treat any disease in medicine, the better the outcome's going to be.
That's great, Mike. We could probably go next hour, but it's such a fascinating thing. But this was great for me because you're implementing the process, you're using it, you're seeing how the results are. Your patients are happier, the patients are more confident with you. There's no bias involved. I mean,
yeah, we didn't go into the bias, but the bias that any doctor, whether it be young or old, senior, junior, they walk into a room, patients wearing, disheveled clothes, patients wearing a suit, looks super healthy. The healthiest patient who appears healthy could be the sickest person you treat every day. You don't know. But the judgment that we basically make by looking at a book and reading it by its cover is so wrong. And when we're busy, that's what happens. And we're busy, on a daily basis. We're trying to run a business. Things that we are not necessarily wanting to address, we have to address in a dental practice. You're in charge of HR. You got to make sure that the patient who's getting treated is being properly treated, that they're numb. And if they're not numb, what are you going to do to get them numb? You already gave them an anesthetic. Why aren't they getting numb? You know, all these different things that go in your head that create stress will lead to you having a bias, missing something. And it's not that you're trying to, it's just that it happens and we're human. So this makes dentistry safer.
Yeah.
Okay. At 42 North, we're building a culture of quality, safety, and efficiency. Artificial intelligence hits all three of those.
Yeah. Yeah. No, that's great, Mike. So, yeah, I mean, I'm just curious. So if anybody here wants to learn a little bit more about Videa Health, I believe it's videahealth.com, if I'm not mistaken. I could double check that. I'll have it scroll across the screen. And actually, if people are interested about 42 North, how do they track you down?
42northdental.com.
Simple as that.
Simple as that. Check us out. You know, we're 115 practices with over 40 different brands that we represent. So
that's great. Mike, what a pleasure. This is just fascinating. And I hope everybody's gotten something out of this and moves everybody on to this next level. So we'll continue our discussions around the year on artificial intelligence. Michael, again, thank you so much.
Thanks, Paul. Have a great day.
You too.